Good evening, everyone. Thanks for joining us today. My name is Sarah. I'm part of RIGAF team. I will be your host for the session. This session is the first part of getting into radiology series, and it's particularly valuable for anyone who is applying for radiology ST1, as we will cover the entire process from the application to the interview stage. And I'm thrilled to introduce our speaker, who is Dr. Qusai. Dr. Qusai Azhari, who is incoming radiology ST1 in Northwestern UK, and he will share his successful journey and valuable tips to help you navigate through the same path. The session will be last for around 60 minutes with the first 30 to 40 minutes presentation, and we will open the floor after that for questions and answers. So in the meantime, please feel free to type your question in the chat. We'll try my best to answer the questions. And also at the end, Dr. Qusai is more than happy to take the questions. With that, enjoy the session, and over to you, Dr. Qusai.
Thank you so much. Thank you for that. And good evening, everyone. Thank you for attending, and thank you for the REGA for the nice opportunity. And I hope all of you will make it to ST1 post in the UK, in the NHS. So I am now at the moment a GP trainee, and I have been in IMT training, and that's telling you everything. I've got the chance to examine and assess the IMT training and then the GP training, but I was very, very adamant to come into radiology. So let's see, why do you need to go into radiology? So this webinar is for the people who are just graduated, naive. They don't know which specialty is the best for them. They will get benefit of that. Not just that, for the people who are pretty sure they are going to be a radiologist, they just need a guidance how to do that in the UK. Again, it's for the people who are still choosing, am I a radiologist? Am I orthopedician? Don't waste your time, just apply for radiology. And we are going to see why. And for the people that they are sure they are not radiologists to be. So we are going to change their mind today. However, why radiology? Generally speaking, because radiology is a very knowledgeable specialty. To be a good radiologist, you really need to have a good knowledge of everything. And to be honest, radiology and maybe just the GP, those two specialties, they are the only specialty that your population is everyone. You see pregnant ladies, you see kids, you see learning disability, you see geriatrics, you see everyone. So you need to have like basic and deep knowledge for everyone. Guidelines for radiation for kids, for example. What is the best sedation for over 65 years old people? So you got to know everything. That's why radiology is amazing. Is a specialty of knowledgeable people. If you are that person who loves to do exams and love to integrate knowledge, radiology is the best place for you. Not just that, radiology is an end specialty. And when we are saying that, I've worked as a GP and I've worked as an IMT before. Being an end specialty, and in fact that you don't need anyone to do your job properly, not like, for example, if you are a general surgeon or A&E doctor, or you call physiotherapy, you call the lab, you ask these people to come, you ask these people to come. And honestly speaking, even this is an evidence base. This is drastically decreasing the job satisfaction. Because if I'm, for example, dedicated physician, medicine doctor, and I spend quarter or third of my duty just calling people, asking review from this department to the other department, and they're not coming and they're resisting. It's a lot of paperwork and non-medical work. I'm not for that. But in radiology, you don't do that nonsense. You are just doing your work and everyone is asking you. You don't ask anyone. And that's really, really maintaining and establishing and maintaining the job satisfaction. And I've never came across any radiologist or radiology trainee who changed his mind and he said, okay, I'm changing my mind, I'm going to other specialty. But I've seen that in medicine, in GP, in surgery, in orthopedic, every single specialty, but not in radiology. Again, radiology is a core, in modern medicine, radiology is a core specialty. You are you are the team leader or the cornerstone of the MDTs going in the hospital. Every single MDT, from mortality, morbidity, obstetric gynecology, oncology. So you have a very vital role in the hospital, diagnosing, even not just diagnosing, even treating patients and following them up. Now, when we are talking about radiology training in the UK, I believe it is the best training program in the UK ever in the NHS because of this individualized teaching. Most of the other specialty, they teach you by experience. You learn by experience. You got to do long shifts, so many on calls, then you got to learn by experience. But it is not the case in radiology. Whenever you get into radiology, you become an ST1, they don't expect anything from you. And they assign one consultant for you to teach you the basics of radiology. And we are going through that in details. So the fact that you are forcefully spoon-fed in the first year, at least, that's again enhancing the overall satisfaction. You got to learn so many things from one consultant just designated to teach you, which is really a luxurious experience. You don't find that anywhere else. And again, of course, you know about the AI and the rapid evolving in radiology. And now we are not talking about just radiologists. We are talking about radiologists who can deal with the AI. And I think there are some echoes. Someone whose mic is open. So if you are interested in technology and AI and keeping yourself up to date, radiology is the best specialty for you to get in. Okay, so in the UK, what do we have in radiology? We have diagnostic radiology, which includes all of the subspecialty that you know, like gastroenterology, pediatric radiology, head and neck, for example, and etc. And we have other subspecialty in the radiology called nuclear medicine. You all know about that, and we are speaking about that shortly, and intervention radiology. So if you are radiologist to be in the UK, you will be one of these three subspecialty, either diagnostic radiology with all subspecialty in it, or nuclear medicine doctor, or intervention radiologist. Okay, so let's talk about the training scheme in the UK and the NHS. Clinical radiology training structure in the NHS. When we say clinical radiology, that includes diagnostic, interventional, and nuclear medicine as well. So it is a 5-year run through. This is a very important piece of information because in the UK, if you are not familiar with the training system here, most of the specialty like anesthesia, internal medicine, surgery, they have core training and then higher training. It's very different from every other country in the world. So you do, for example, in medicine, you do 3 years. They call it core medical training for 3 years. After 3 years, you are not eligible for any certificate or anything because, for example, in the US, if you are doing medicine for 3 years, you are hospitalist. Now you are certified to practice as an independent specialist. It is not the case in the UK. You do core medical training for 3 years. There is no certificate, nothing. That will just qualify you to apply for higher training. Then you apply, for example, for cardiology. You spend another 5 years. So it's 8 years in total. 3 years core medical training, and then 5 years higher training. It's not even subspecialty, it's higher training. Most of the higher training, you finish them, you got your certificate of completion of training with subspecialty. Most of them, yes, you got your subspecialty already. But generally speaking, you got core training, which qualify you for nothing, just to apply for higher training. Then the higher training itself, which by the end of the higher training, you got your certificate of completion of training because your aim is the CCT. In radiology, it is not the case. It is just run through. You start from ST1, you finish by ST5. This is again feeding up the satisfaction of the trainee. I don't want to finish course training, then get out of the training, then apply again. I might not find an opportunity. It's not the case. Once you got the ST1, it's just run through till the end of the ST5. But if you are pursuing an interventional radiology IR, it is an ST6, it's 6 years. So for nuclear medicine, for diagnostic radiology, it's 5 years. For interventional radiology, it's 6 years. There is a 1 year extra. So successful completion leads to CCT, which we are talking about. So in the UK, if you are finishing training to get a specialty register to be a specialist or consultant, you need to acquire the CCT. So relatively speaking, radiology training is one of the shortest training ever in the UK. GP training is 3 years, for example, but all of the other trainings are minimum 6 years, like psychiatry, 3 core training, then 3 higher specialty training, anesthesia, for example, 3 and 3, things like that. But radiology is relatively short, and you become a consultant in a very young age. Okay, so interventional radiologist, if you pursue interventional radiology training, you got dual CCT in diagnostic radiology and CCT in interventional radiology. You have 2 qualifications. For nuclear medicine, again, it's the same. You will have CCT for diagnostic radiology or clinical radiology and CCT for nuclear medicine. Just give me 1 minute. Give me some. So, what are the types of training scheme in the UK if I'm about to be a radiologist? This is a very important information you have to know. And especially at the level of the application, you have to know what are you applying for. So we have 2 schemes of training. The traditional hospital-based training, like elsewhere in the world, you go to the hospital, you had 4 month shift or 6 month shift according to the deanery and trust. Then you keep rotating till you finish. This is like a conventional or traditional hospital-based training, like everywhere else. And as I told you, you assign to one consultant, he's teaching you. The other type of training, which is really, really interesting, it's academy-based. What does that mean? So, because they are, as I told you, radiology is, for me, is the best training scheme ever, especially in the NHS in the UK. They adopted a new style of training. It's the academy-based. You go to the hospital, yes, and you go to the academy. Academy is a university, is this university or academy designated for the radiologist, ST1, ST2, C3, and the deanery will assign you there, and you will have some live simulation in the academy, like live CT reporting session, live MRI reporting session, like simulation for musculoskeletal, for example, if you want to give an injection to do procedures. So it's very sophisticated academic. It's not academic that you are doing more researches or non-clinical. No, it's academic in terms of you have equipped place to simulate a lot. So you have the hospital-based experience, but you have something very constructive, structural way of training. And it is not everywhere in the UK. So maybe 6 or 7 deaneries around the country, across the country, they do the academy based, and they are very competitive because people are really up to that. So one of the very famous academy based training, it is in the peninsula, southwest, then in Norwich, and the east of England, and northwest, because I've been accepted there in the northwest. So in Leeds as well. So they are competitive, more competitive than the other posts, and because they are adopting this hybrid way of training. Okay, so the training pathway in the UK for the radiology, you start by ST1 up to ST3, which is the core training. It's basically the foundational skill for the radiologist to be. You got to rotate across the all subspecialty, X-rays, MRIs, CT scans, ultrasounds, chest, musculoskeletal, gastroenterology. So you got to rotate everywhere to grasp the basic knowledge of the radiology consultant from ST1 to ST3. By ST3 level, you have to apply for subspecialty. That doesn't mean you will go out of training like the other trainings. No, it's run through, but you have to choose your subspecialty. If you are choosing nothing, it's easier to go into diagnostic radiology than to choose one of the subspecialty. This is like the default one. But if you opted out for nuclear medicine or intervention radiology, you have to like tailor your application in a way that you will be accepted. So they will ask you, because we all understand intervention radiology is very competitive. So you got to finish your ST1, ST2, ST3. You got to do your FRCR part 1 and part 2. Then by ST3, you apply for example, if you want intervention radiology, you apply for intervention radiology within your deanery. Then you'll be, for example, 20 or 30 applicant, and there are 1 or 2 posts. You compete for the post. Not all of the candidates will apply for intervention radiology, of course, maybe 10, 15. So you got to compete. So you got to have very good CV or portfolio for the ST4 post. So higher training is ST4 and ST5. For clinical radiology, for example, if I'm continuing in diagnostic radiology, by the level of C3, I will choose, for example, CNS or head and neck, or for example, gastroenterology or musculoskeletal, whatever. Then I will continue to do ST4 and ST6. And ST4, I will do 60% of musculoskeletal or CNS or whatever the specialty is, and 40% of general radiology. By ST5, I will do the opposite way. 40% of the general radiology and 60% of my specialty. But if I'm going for intervention radiology, it will be ST4, 5, and 6 in intervention radiology plus general radiology. You don't lose the skill that you have learned. And it is the same in nuclear medicine. However, nuclear medicine, interestingly, you can get into nuclear medicine posts in 2 pathways, from radiology, ST1, ST2, ST3, then you apply afterwards, or from the medicine training. You do your core medical training, IMT1, IMT2, IMT3, then you do your MRCP, then you apply for nuclear medicine. So nuclear medicine, hence the name is nuclear medicine, you can get into that from 2 pathways, either from radiology pathway or from internal medicine pathway. So again, when you are going to apply, what are the posts that you will be offered to apply for? You have 2 posts. Either you apply for normal post, which is diagnostic radiology ST1. They are around 300 posts. Or now, 3 years or 4 years back, it's something very brand new. The RCR, they adopted some posts. It is intervention radiology from the start. So you start ST1 as intervention radiology. You don't need to wait for ST3 to apply. However, that system is still there, most of the deaneries, but we have like almost 25 posts over the country. They are directly ST1 in intervention radiology. However, the train would be ST1, ST2, ST3 core radiological training. By ST4, you don't need to apply because you have been accepted already. By ST4, ST5, ST6, you will move into intervention radiology. So they are just 25 posts across the country, and they are very competitive as well, because it will save a time and will give you like a peace of mind. If you are intervention radiology, you apply for them, you keep them up. So basically, you will have to arrange your preference. If you are up to intervention radiology, you keep these 25 posts top, then you arrange the rest of them. Okay, so let's speak about the competition ratio, because this is a really hot topic around the radiology in the UK, because it's very, very, very competitive. Okay, so look at the figures here. If we are, for example, checking the pediatrics, look, we have 480, almost 480 posts per year, and we have 1,000 and half applicant. So it's 3 to 1 for pediatrics, roughly. Okay, so for GP, we have 4,000 posts available, and we have 15,000 applicants. It's again 3 to 1, or almost. When it comes to radiology, fourth from the bottom, radiology, we have, this is the statistic from last year, 2024. This year's statistic hasn't been published yet. It will be published maybe next month. Here, this is the most recent, 2024. For radiology, last year we had 312 posts, and the applicant were 3,800 or 700. It was almost 12 to 1, 12 applicant to 1 post. It was very, very competitive. The only specialties or subspecialties that are more competitive than radiology are if you can see here, the ophthalmology, the neurosurgery and the cardiothoracic surgery, and the reason for that, not because they are more competitive than radiology, but because they offer very limited posts. For example, cardiothoracic surgery across the country, where there are 70 million people, they have just 9 posts per year. 9 posts. That's why it's very competitive. Neurosurgery, for example, they have 18 posts. That's it. Ophthalmology, they have 90 posts. In radiology, you have more than 300 posts, but the competition is very high. Does that mean I need to be scared or to stop working? No, because hence why this presentation is there, to break down the bits, the difficult part, and the tricks to guide you to short your time cut. Okay, again, these are the graphs of the competition ratio. We've seen the competition ratio for cardiothoracic surgery, neurosurgery, ophthalmology, and radiology. It was 1 to 11.9, which is 1 to 12 almost. That was last year. I believe this year it was even harder than that. So radiology in 2022, we had 2,200 applicant for 360. So the competition ratio was 1 to 6. In 2023, again, the applicant jumped from the applicant number from 2,000 into 3,000 applicant competing over 350 posts. So it was 1 to 8.7. Last year, it was 1 to 12. But look at the last line. It's very important. Now, this is the ratio between the applicant and the posts, which sometimes it's like false positive kind of thing. Why? Because, and we are going to mention that after the MSRA exam, if you've heard of that exam, it's like a shortlisting exam or like entrance exam or like general exam to shortlist the people. After that exam, it's always like that. 700 candidates, they are fighting for almost 350 posts. So it is 2 to 1. If you pass that exam, I wouldn't say pass because it's not about the pass mark, about the scoring, the cut score of radiology. So if you score that cut score, you are fighting for 50%, 2 to 1. 2 candidates fighting for 1 post, which is fair enough. So they make, in a way, they kept the cut score for radiology very high. So they take the upper 700 applicant and they interview them and they will choose just 350, half of them. So again, the competition ratio of radiology is just like steeping curve. Look at this, the green one. By the year of 2020, it was somehow not that hard, but by 2021 and 2022 and 2023, the curve is just going upward. So all people are just applying for radiology, and the applicants from outside the UK are much more than the applicant from inside the UK. So who is eligible to apply for radiology in the UK? Everyone except someone who worked more than a year and a half in radiology. So the RCR is saying he is not eligible to apply with the people who are naive, because our aim is not to get someone who is radiologist. No, we need someone who is good SHO, has good medical knowledge, has good understanding of the GMC guidance and good medical practice and the SGT concepts. So we will teach and train him. We don't need someone who is already trained. So that's why if you worked for more than 18 months in radiology, you are disqualified. You cannot apply. Or someone who is working less than 2 years from the start till the start of the post. For example, now usually the window will open in late October, but the post will be commenced on next August. So calculating from next August, if you are working less than 2 years, you are not eligible to apply. Why? Because the foundation system in the UK is 2 years, F1 and F2. It's just like the internship or the housemanship elsewhere. So they have 2 years, F1 and F2. So you need to be equivalent to them, at least to have 2 years of experience till the date of the commencing of the post. Then you are eligible. So everyone is eligible. Don't say, oh, I've graduated 10 years, 15 years ago. It doesn't matter. Don't say I'm almost senior registrar in surgery. It doesn't matter. So this is the application timeline. It's very important. The application window open in Oriel system, which is national system online, in October, late October every year. Then after you apply, they will ask you to upload something called CREST form. If you are not doing the foundation paper in the UK, CREST form basically is a form that the consultant is saying my doctor is equivalent to the foundation doctors in the UK, and they know how to do history, things like that. It's a fixed form, it's just you tick on that. So that means you are now long-listed, you are eligible. After you have been long-listed, the long-listing process is just about the CREST form. After the long-listing process, now they will invite you, if you are long-listed, to sit for the MSRA, which is multi-specialty recruitment assessment. From the name, it's selection exam, general exam, and this exam is for maybe 13 or 14 specialties, not just the radiology. So usually the window for the exam is early January. You book mid-December, but you sit for the exam early January. Then during the application in October, they will ask you to self-assess yourself. What does that mean? They will ask you to upload to score for yourself your portfolio, your CV against the criteria they are assessing you. How many audits, how many paper, how many. We are going through that as well. So then you assess yourself, you mark yourself. Then in February they will ask you to upload the evidence. So you mark yourself in October, but you upload the evidence in February. Why is that? Because they thought the applicant number is increasing exponentially. So we are not assessing and verifying that huge number, but we are assessing or verifying the uploaded evidence after we shortlisted people. So after the MSRA exam in January, in February, they will ask you to upload. That means the result of the MSRA is very close. Then after the result, if you are shortlisted, they will assess your and verify your evidence. If you are not, they will not do that. Then in March, they will publish the dates and slots for the interview. You have to book that through Oriel as well. If you have been shortlisted, if you scored the MSRA score, you will be invited to sit for the interview. Usually the interview is a 1 week, and you choose the day and the date and the time. Then late March and early April, they will start publishing the offers. And I hope you all got the offers. So you have 3 key steps in your journey. You need to start with MSRA. This is the first rate limiting step. It's very important. And the MSRA in the past used to be used in the overall total scaled score. Now, since this year, is not the case. MSRA score is not part of your scaled score, the final score in the ranking. No, it just pass or fail. Either you are shortlisted or not. Whatever your portfolio was, if you are not passing the MSRA, like you have done nothing, because they are not going to look into it. They are not going to invite you to interview. So you have to score the passing score of the MSRA. Last year, the passing score was not the passing score, the cut score for the MSRA for radiology was 555, which is very, very high. Then they decreased it up to 549 the same year, and they accommodated extra 100 candidates. They kept them after that. However, this year, the exam was very, very tough, especially the SGT. So the average score has been low. So the cut score for radiology was 544. And I would say 544, it really equals to 555 last year because the exam was tough. So if you are scoring 544, you will be invited to interview and to upload your evidence. Then, now let's calculate the total scaled score. They will take 40% from your portfolio, and we are going to check on that as well, and 60% from your interview. So let's say I scored whatever score in the portfolio, they will times it by 40%, then 60% will be from your interview. Okay, so let's break them down. The MSRA. So the MSRA is multi-specialty recruitment assessment. It's a GP-based exam constituted of 2 papers, clinical, as you see, and SJT, which is situational judgmental test, which is ethical scenarios. So the clinical is 97 questions. You got to solve them in 75 minutes, and there are 11 questions. They are not weighted in the score, but you don't know which is which, so you got to solve them all. Pilot's questions. In the SJT part, You have 50 questions in 97 minutes, tighter time. It's very, very tough. We are going through that as well. You have 8 pilot questions. They are not countable. They are not counted. And you have 2 types of questions, ranking questions. They will give you a STEM scenario, and you will ask you to rank the responses, which is the best, second to best, third, something like that. And there is another type of question, which is a 3 best of 5. They will give you STEM, ethical scenario, and they will ask you to pick the best 3 of the 8 options. This is about the MSRA. MSRA honestly needs a like a separate webinar to talk about it. It's a very tough, very big topic. So the portfolio, let's focus on the portfolio. You have 7 domains. The total score of the portfolio is 45. And let's say I've scored 30 of that 45. How would they gonna score me? They will get the 30 and they will times that by 40%, which is basically you got your score 30 and you times it by 0.888, because that is 40% over 45. So to make it easy for yourself, whatever score you score, times it by 0.888. If you scored 45 times 0.888, you score 40. So the total score is 45, and it will be scaled it into 40%. Let's go through that. So the first domain is commitment to specialty. It is of 10 points out of the 45 points. And this is, believe me, it's just like an revealed or open test or exam for yourself. You got to work very, very hard to score very high in the portfolio, because something open, you can work on that. It's nothing like unexpected. You know what the criteria are. Just work hard for them and score well, and you will know by the end of that webinar why this is very important. However, the first domain is commitment to specialty. You can see how do you score 10 out of 10 in that domain by doing 2 tester placement. What does tester placement means? You go to radiology department, you ask them to work with them like an observership, short observership for at least 3 days. Then you go for other radiology department in different hospital. You spend other 3 days. They got to be different. One teaching hospital, one simple hospital, what we call in the NHS DGH, District General Hospital. So you got to make them different experience. So you got 10 out of 10. Why? Because they will count as a multiple significant exposure, as you can see. Multiple means more than one. Significant means 3 days or more exposure. So tester placement is the best thing, which is observership, short observership. Or you can do one observership and, for example, attend 3 MDTs, or 2 MDT and 1 intervention radiology list. So they have criteria and they are well explained here. So you got to score at least 10 out of 10, because these are very free marks. You are not losing these marks. The other domain is the leadership and management. Is a little bit tougher. So to score 7 out of 7 points, to score 7 out of 7, you have to hold a position for 6 months, and they need to be in national or international level and to be radiology related. For example, RCR representative in the UK, in the England, for example, for 6 months, something like that. You can score less, score 5 out of 7 by doing, if you can read the descriptor here, having national leadership or managerial role that's in radiology, or international but not radiology, something like that. So they are well described, and I will leave the presentation for you, don't you worry. So you got to read them carefully and to try to work hard to fulfill the criteria. Why? Because any single evidence that will be accomplished after the starting date of the application window would be disqualified. You have to finish everything before late October. If you finish, for example, audit by November, they will not count that. You need to finish it before the application window. That's one. So you have the third domain is the teaching domain, teaching and training. You got to score 5 out of 5 if you have major contribution in national or international teaching program. Can I score in that easily? Yes, you can work in your hospital. Not just teach, just organize teaching. If the consultant is doing teaching, for example, for foundation doctors or medical students, you got to organize that, to choose the topic and arrange between them and do that for 3 months at least. And you got a certificate. Now you got not the full mark, but you got 4 out of 5, which is fair enough. So you got to be very clever and smart to measure contribution. So it doesn't need you to teach yourself. You can just organize. Okay. So again, the fourth domain, formal teaching. This is maybe the most difficult one. You need to have formal qualification teaching like master or PhD or something like that. There are very useful, easily going, I wouldn't say free, it's semi-free online courses. They call it training of the trainer, TOT. You got to do them, you got to have the certificate. It will grant you for 2 points at least, because believe me, you are competing with very dedicated radiologists to be. You need to have every single mark here. If you don't have master or PhD, fair enough, at least got to do that online course to get 2 points at least. Okay, so the fifth domain of 7 points is the audits and QIBs. You got to score 7 out of 7 because they are easy marks. You don't lose that marks. To score 7 out of 7, you need to do 2 audits or QIB/QIB, 2, and they need to be radiology related, and you need to be the primary investigator, and you need to show second cycle in QIB or audits. It's very tough, I know, but you need to do that. You need to score 7 out of 7 in this domain because everyone is doing that. The sixth domain is of 5 points. It's academic achievements. I think this is the last one. No, sorry. Academic achievements. If you got any international prize, if you done any poster, if you published any paper, again, bare minimum, you can at least nominate yourself or just like compete to be the doctor of the month, for example, in your hospital, something like that. If you've done that multiple times, they will give you 2 out of 5. Fair enough. So you got to have something at least. Or if you have a university-based, no, this is not here, I'm sorry. So you got to have something here, academic achievement. So the prices, yes, I've mixed up, sorry. The domain of academic achievement, you have to have master or PhD or publication or poster. Bare minimum, you can at least present your university, for example, university research in any international conference. They will give you 2 points. If it's radiology related, it'll give you more points. If it is publication, will give you full marks, 5 out of 5. It's a tough one, to be honest. So the last domain is the prizes. If you got a prize, which is international by radiology organization for a paper or for a presentation or something like that, it will give you 6 out of 6. So the bare minimum, again, you can apply for Doctor of the Month in your trust or hospital, for example. If you got a prize within your university, they will count it. But I've heard that they disregarded the university prizes this year. So, are there any changes in the portfolio? Yes, there are, like supposed changes. The RCR themselves, they announced that the recruitment office, they announced that. So they are merging some domains. They are reducing the domains from 7. They will make them 5. So there are two domains that wouldn't be there. How come? They will merge domain number 3 and 4, the teaching and training, with the teaching qualification. It makes sense. So they will keep them as a one domain, and the last domain of the prices, they will take it off. So we have 2 domains, they will merge together, 3 and 4, and one domain will be eliminated. The prices and for me, I think that is easier for us as an IMD because it's difficult to get an international prize. So they will take that off. Is it something 100% sure? No, not confirmed, but they proposed that. So let's talk about the interview. The interview so far is 2 stations, each minute, 10 minutes each. How would you pass the interview? The interview of 60 mark, you got to score 36 at least in total, and 16 at least in one station. So you cannot score 16 and 16 and pass. No, you need to score 36. And you cannot score, for example, 25 in station and 15 in one station. You are not passing. You have to score 16 at least in the station and 36 in total. If you are doing very well in MSRA and very well in the portfolio and you are not passing the interview, you are not appointable. You are losing everything. So you got to pass the interview as well. So we say the portfolio is in total of 45 marks that will weight 40%, and the interview of 60 mark that will weight 60%. So every single mark is 1%. If you are scoring 50 in the interview, you are scoring 50% automatically. If you are scoring 30, it's 30. That's that. So you have two stations. One station is a clinical station of 30 mark, as we say. You have two questions in this station A, which is the clinical station. It is like prioritization station. They will ask you, you are on radiology ST1, out of hour or in hour or weekend or whatever, and you don't need radiological information. You need to be very competent SHO. So they will ask you, you have these five cases. One has been stabbed in the chest, one is vomiting blood, and one, for example, having fever, and one is having sudden weakness. So which scan would you vet? Vet means you'll authenticate. Which scan you would vet first? You had CT scan head or MRI pelvis or abdominal ultrasound. So they will give you the scenario and they will give you the modality. Which one would you pick first and why? So you got to be very systemic. You are acting like an ABCD approach, which is more urgent, and you got to be very clever. Which modality will change the plan of management? Even if the situation is very top emergency, but the modality is not changing the plan of management, you don't pick that up. It's not just like that. You have to be clever. So prioritization question is of 10 marks, because there are 5 or 4 cases. So it's out of 10. You will be scored 5 marks because you have 2 panelists, 2 interviewee. One will give you 5. Will mark you of 5 marks, and the other one will mark you out of 5. So it's 10 in total, but they will times that by 2. What does that mean? So we say we have 2 stations. Station A constitute 2 questions, and station B 3 questions. Every single question in station B of 10 marks. So 10, 10, 10, that's 30. In station A, we have 2 questions, one by 20 marks and the other one by 10 marks. So 60 in total. So the clinical prioritization question is the most important, because if you scored, for example, one panelist gave you 4 out of 5, and the other one gave you 3, so you scored 7, they will times that by 2. So your score is 14 out of 20. So you got to work very hard on that to score, for example, 10. So you got 20 out of 20. So in station A, you have that clinical prioritization. Then you have other question, which is understanding the specialty. They will ask you, what do you know about the training scheme? What do you know about the radiology day-to-day activity, the ST1? What do you know about the exams? They will ask you something about the radiology training scheme in the UK. Okay, and this is of 10 marks. Station B, it's about commitment to specialty. They will ask you 3 questions. First of all, question about coping with the pressure. They will ask you, if you are, tell us about the situation, for example, when one of your colleagues was underperforming, or the team was underperforming, or someone committed a mistake, or you yourself committed a mistake. You have to be very ready for that type of question. There is a very professional way to tackle that type of question. Okay, so other question will ask you about teamwork. How would you support one colleague? Or for example, you are feeling unsupported, what would you do? Or one of your consultants, for example, being seen drinking alcohol during something like that. So, and the last question would be about radiologist to be skill. Okay, tell us about important skills for radiologist to be, or why do you choose radiology, or what do you know about the skills that the radiologists need to have, things like that. You got to be very good on that. So the proposed change, they will add 3rd station about the portfolio. That's why they took the prize domain off. So they are proposing this, the interview would be 3 stations. Station C would be about your portfolio. So they will assess the portfolio in verification process, but they will ask you, you have done that. What do you know about that audit? Tell us about something like that. They are not confirmed yet. They are proposed. So how to prepare for the interview? Because interview is 60%. Come on. So there are courses for the interview to prepare for the radiology interview. One of the most famous courses is RADCAST. course, and the other one is UKRC. I really suggest you joining UKRC group. They are very helpful and they have very useful resources. Most of my statistics and things, they are from them, to be honest. So UKRC, you got the link, and they have very useful WhatsApp group. You need to reach out on the private, so I will connect you with the group moderator, so you can ask them privately to add you to the group. And there is a course called the Radiology Interview course as well, and there is course in London called the London Radiology course. So this is the source number one. Source number two is the individual practice. You need to practice with a group of friends or something. You need to practice every day to make it like a subconscious. You need to practice. Number three, which I found it was very useful, is trust level. What does trust level mean? The level of your own hospital. If you are working in the UK, the radiologists in the trust means the hospital. In the hospital, they will gather together and they will volunteer to help the radiology applicant by arranging a mock exam for them. It's very common practice. And number three, online mock. If you know about the Sudanese Joint Doctor Association, SAJDA, I've done mocks with them. They are free. They are very helpful. Qualified doctors, and they are helping people a lot. So they are the proposed change to the portfolio, reducing the domain from 7 to 5, merging domain 3 and 4, removing prices and awards, introduction, portfolio station interview, and removal of the verification process. This is the thing that I missed. So they are not asking you to upload and then they will verify that. No, they will assess that in the portfolio. They are just proposed yet. So important statistics in 2023-2024 last year, the total posts, this is a very important slide, were 293 posts, which is very less number, very less. But they kept adding posts, and we ended up having 312 posts for radiology. We are competing over these posts last year. So the last score that got any offer in the first wave, because when they published the offers, everyone would accept or reject, then they will recycle the offers. We called it waves. So the first wave, the last rank that got an offer was 321, ranking number 321. They rank people. And his or her score, total score, was 71.9, which is very high rank, which is very high score. So every 48 hours, they will recycle the offers. So last year, the last score was 69.6. and the ranking was 370. So the one who ranked 371 got no offer, unfortunately, last year. However, this year, the posts were 326 and they added 2. So the total post was 328, much more than last year. And the least score got an offer from the first wave was 69.667. The ranking of that candidate was 348. Okay, so this year they came down, they kept recycling the offers. So the last one got an offer, because usually you got an offer by April, no later than that. But this year, for some reason, they kept recycling the offers, and some people kept withdrawing the offer till the ranking number 430 got an offer. What does that mean? That means you need really to pass the interview and to score good score and to pass the MSRA and between brackets to be appointable. So if you are appointable, you might get an offer. You might be lucky. So to be honest, ranking number 430 to get an offer, it was very unexpected. But why did that happen? I'm telling you, because a huge amount of number applying for radiology. They knew they are orthopedician to be, or surgeon, or everyone is applying for radiology. So somehow it's unfair, because you are a radiologist to be, you are competing with someone who is not. He is not radiology, but he is applying for radiology as a backup plan, because radiology is a good specialty and the satisfaction is high. So they kept it. So they primarily want to go into ophthalmology or neurosurgery or whatever, and they're applying for radiology. If they didn't give that, they will just go for radiology. So a huge number of people, they've done that this year. So there were some vacancy after they closed the application process. So someone, for example, like me, has been offered the radiology in some place, and I'm up to ophthalmology. I was waiting. Then I got my ophthalmology. Then I withdraw my radiology application. So they will recycle that. They will recycle that for the next coming score, and they kept doing that. That means a huge number of applicants, they kept radiology as a backup plan, and they are initially not radiologists. So how that would affect me? These people will increase the curve, or keep the curve high, and the MSRA score will be higher, because you are not competing with just radiologists. You're competing with orthopedician and ophthalmologists. Everyone is applying for radiology. That's why. How would you calculate your score? For example, you scored in the portfolio 28 out of 45, and in the interview you scored 45 out of 60. How would you calculate that? The scale score would be 28, which is the portfolio, times 0.88. Why? Because you got to divide 40 over 45. So your portfolio scaled score would be 24.8 plus 45, which is 45. So your total score will be 69. Why I'm giving you this example? Just to let you know, if you are scoring 45 in the interview and scoring 28 in the portfolio, you are just on the edge. 69. Classically, historically, if you are scoring 70 or 71, you are getting an offer. Inshallah, you are getting an offer. So to be in the safe side, you got your total score to be 70. Now it makes a lot of sense, and it's easy and straightforward and direct. You know how to work. Your MSRA, you need just to score the cut score, then leave it behind your back. Now focus on the interview and portfolio. In the portfolio, don't score less than 28. You will make life difficult for yourself. If you score 28, I'm telling you, 28 is the one of, if there is an hypothetical normal rate, it is on the lower side of the normal range. Less than that, your opportunity is very, very less. You are competing with very dedicated people. So at least score 28 in the portfolio, and at least score 45, 46 in the interview. So your total score would be around 70. You will get an offer. I gave you two examples of 2 years. One year was very, very tough. The posts were very less, and the recycling process was limited. No one withdrew anything, and they ended up by accepting up to 69.6, which is very tough. This year, a lot of people moved out and accepted other offers because they kept radiology as a second option. So they came down up to 65. So to make yourself on the safe side, just score up to 70. Again, these are very useful resources. For the MSRA, we have two resources. We have like a channel. We are posting the resources for the SJT exactly, not the clinical part, the SJT. You go to, you will have the presentation anyway. So you go to scan and go to the channel. You got the resources there, and there is a Sudanese MSRA WhatsApp group. They discuss and they study currently about the MSRA, clinical, and the SJT as well. It's open for everyone. And this is my personal Telegram. If you want to ask anything about the interview and the SJT, I would be more than happy to know that. And again, what's that? Stay consistent, learn from mistakes. This advice is not reliable. I'm just giving them to make a more formal presentation, but you got to know what you want to do. The MSRA, how to tackle that. Then the portfolio, you need to score at least 28, and you have no excuse. And when it comes to the level of the interview, there are options and ways. So first of all, pass the MSRA, and then work hard on the portfolio to make life easier for yourself. If you are scoring, for example, 40, 36, which is very tough, you need to score at least 40, 42 in the interview, and you will get an offer. You need to score 70. And again, these just for the sake of it. I'll be happy to have any questions.
Thank you so much for this really valuable session. And for now, we are more than happy to take questions. If anyone got any questions, feel free to unmute yourself.